Welcome back. In this lecture, we will address psychopharmacology for children and adolescents. We will discuss ADHD core symptoms, differential diagnosis, neurobiology, brain structure abnormalities, and moreover, pharmacological treatments to include side effects. In terms of objectives for this lecture, upon completion of this lecture, you shall be able to identify ADHD, age of onset, define ADHD core symptoms, and define ADHD diagnosis, and explain the neurobiology and frontal lobe dysfunction. Discuss pharmacological treatments and side effects for the disorder addressed in this lecture. Now, ADHD, age of onset, the majority of these clients, they show symptoms before the age of 2. The majority of these clients that are properly diagnosed with ADHD, they hopefully by the age of 4, they tend to manifest symptoms. Now, the DSM-5 recently has pointed out that in order to meet the criteria for the diagnosis, the child needs to meet the age of 12 years in order to be properly diagnosed. Now, ADHD affects approximately 5 to 7% of children with neurological maturation. Most teenagers with ADHD will experience a noticeable reduction in motor activity. And then, of course, we begin to see physical sequelae such as restlessness and also hyperactivity. ADHD core symptoms of this diagnosis continue throughout adolescence and on into adulthood. And again, we begin to see physical sequelae where the child begins to display impulsivity, impaired attention, and lack of intrinsic motivation. Now, the experts in the field of attention deficit hyperactivity disorder agree that about 1/3 of ADHD children completely outgrow the disorder by early adulthood. It is likely that due to the ongoing maturation of the prefrontal lobe of the brain, which may continue till the early 30s, may be the reason. Now, the diagnosis of ADHD is based largely on 3 sources of data. Family history is the first one. Since this is a diagnosis that is considered to be genetically transmitted, it runs in families. ADHD is also a diagnosis of exclusion. On this note, let me share with all of you the exclusion list. The first one, diffuse brain damage due to fetal alcohol syndrome. Second, bipolar mania. Third, agitated depression. 4, pre-psychotic conditions. And 5, academically understimulated children in the classroom, or in other words, BOR. Now, ADHD, the most common presentation for ADHD is at an early onset, in other words, in infancy, where the child begins to experience restlessness, unstable sleeping pattern, affective lability, such as crying a lot, and difficulty being soothed. Again, when properly diagnosing these clients in a clinical setting, please proceed with caution because it may not be bipolar disorder. Most true ADHD children that have been properly diagnosed are normally seen in preschool settings when they have their first sustained contact with other children and encounter social standards, where there are expectations to control behavior, follow rules, or be able to stay on task for age appropriateness. Now, the emerging data suggests that some children are destined to have bipolar disorders and may show early onset behaviors that are ADHD-like. Now, prodromal symptoms of bipolar disorder are also seen where the client begins to display irritability, aggressiveness, sleep disturbances, depression, mania, and hyperactivity to include anxiety and also mood swings. Now, in terms of the neurobiology, there are numerous studies that suggest impaired frontal lobe functioning in people suffering from ADHD. Abnormalities have seen or have been shown in the dopamine neurotransmitter system, or in other words, in the dopaminergic system of the brain. Likewise, dopamine agonists are effective medications for reducing symptoms of attention deficit hyperactivity disorder. Stimulants such as Ritalin, bupropion are effective in the treatment for this disorder. Now, there is a new medication that was recently developed. The name of the medication is called Cylert, also known as Pemoline, which is a central nervous system stimulant. And it is structurally dissimilar to the amphetamines and also the methamphetamines. Now, in terms of brain structure abnormalities that are associated with ADHD, the smaller right prefrontal cortex has been noticed or has been seen in individuals that have been diagnosed with ADHD. We also have seen smaller cerebellums. Moreover, a decreased volume in the basal ganglia and smaller caudate nucleus, very specifically in individuals properly diagnosed with attention deficit hyperactivity disorder. Now, in terms of frontal lobe dysfunction, we also have noticed that there is a decrease in frontal blood flow. We also see hypofrontal glucose metabolism and also a decrease in spinal fluid dopamine metabolites, and finally, a marked increase in dopamine reuptake transporters. Another thing that I think it is important to consider and to take away from this class is the fact that in terms of neuropathology or neuroanatomy, the cortical thinning that is also seen in individuals diagnosed with ADHD is also of clinical attention. We begin to see that the brain begins to shrink or decelerate, and of course we begin to see cortical thinning. Now, frontal lobe symptoms, we begin to see difficulties inhibiting behavior where the child tends to manifest symptoms of impulsivity, which in a way it's an inability to stop maladaptive behaviors. We also have seen in these children that they tend to have or suffer from impaired executive functioning. Why? Because we know for a fact that the frontal lobe is affected. And we begin to see impaired self-monitoring deficiencies. We also begin to notice deficiencies in intrinsic motivation. Now, in terms of pharmacological treatment, the medication of choice to treat ADHD are stimulants. And these are mechanisms of action. These are neurons that promote vesicle release, a release of very specific neurotransmitter as known as amphetamines. And they tend to inhibit the reuptake of very specific neurotransmitter known as dopamine. Now, in terms of stimulants, one thing to remember and to take away from this class is the fact that stimulants are fast-acting. Methylphenidate, also known as Ritalin, it's normally prescribed in a clinical setting between 10 to 60 milligrams. Now, Concerta, 18 to 54 milligrams, is also prescribed for attention deficit hyperactivity disorder. Now, individuals suffering from antisocial personality disorder with a comorbid diagnosis of ADHD may also be prescribed Ritalin in a range between 10 to 60 milligrams. And anyway, dexedrine, it's another medication that I like to bring to your attention. It is also a psychostimulant. and it's normally prescribed in a range between 5 to 40 milligrams. Amphetamine mixed salts, also known as Adderall, are normally prescribed between 5 to 40 milligrams. Now, stimulant side effect management for medical or psychiatric conditions, if you will, such as insomnia, these side effects can also be treated very specifically for clients that are suffering from attention deficit hyperactivity disorder that cannot fall asleep. The medication of choice would be clonidine for kids or teens. And for kids, it is normally prescribed between 0.05 milligram, and in teens, it is normally prescribed at 0.1 milligram. And then, of course, we have trazodone, which is also a very good medication to deal with the side effects of the psychostimulants. Like, for example, Remeron can be prescribed between 7.5 milligrams to 15 milligrams. And then, of course, we have melatonin, which is a medication that can be bought over the counter, or in other words, OTC. It's melatonin. Melatonin is normally prescribed between 1 to 3 milligrams. And then, of course, in the treatment for anorexia, there's also another medication that can also be used, which is Focalin, which is a medication that is also utilized to treat attention deficit hyperactivity disorder. Now, in this lecture, we addressed emerging data. We targeted ADHD core symptoms to include differential diagnosis, neurobiology, brain structure abnormalities. Especially, we addressed the frontal lobe, which is responsible for executive functioning. And finally, we addressed pharmacological treatments to include side effects of psychostimulants. And of course, there is more to be learned. But on this final note, I'd like to thank you, and as always, I wish you the very, very best in your professional endeavors. Thank you.